Namaskar and good evening, everyone. I welcome you all for today's webinar on management of metastatic non-small cell lung cancer, a newer paradigm. And with immense pleasure, I would like to invite Dr. Deepak Singla, who is medical oncologist at Indus International Hospital, Mohali, for the welcome and introductory note and to take the proceeding forward. Over to you, sir. The floor is all yours.
Yeah. Good evening. Uh, Thank you, Ekta, for this kind introduction. I would like to welcome you all, and I'm really thankful to you that for sparing your valuable time. So today's, although metastatic non-small cell lung cancer is a very wide topic, today we will be discussing of only what is the role of VEGF inhibitors and what is the genomic testing we should be done, and the role of atezolizumab in the non-small cell lung cancer. Without wasting much time, I would like to welcome our colleague, Ms. Charu Bahal. She's a molecular biologist in the Medicinome Lab. So over to you, Charu, please.
Thank you, Dr. Deepak Singla, for the kind introduction. So, uh, 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 I would like to thank for giving me the opportunity to discuss upon something which is very interesting, and personally, I am very much interested in discussing this particular topic. So, the topic which has been assigned to me is role of molecular markers in carcinoma lung. So I'm taking care of the scientific affairs and medical advisor role in Medicinome Labs from past almost 2 years now. So definitely, as we all know, non-small cell lung cancer is particularly one of the most rapidly growing cancers, and it is having mostly in terms of the Globocan 2020 data. India reported around 72,510 cases, which is 5.5% of all the cases of cancer cases in India. And the subtypes includes adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. And over the last 20 years, there has been a shift in treatment from cytotoxic chemotherapies to personalized targeted therapies that act on specific genomic alterations. So those are the genomic alterations which I will be talking about in depth today. And if we look at the percentage of patients with advanced non-squamous non-small cell lung cancer, almost 50% of the patients have a driver mutation which can be targetable with an FDA-approved drug or maybe put on a clinical trial. So coming to frequency of different oncogenic drivers. So this is just a pie chart which focuses on percentage positivity of different biomarkers which are prominently found in non-small cell lung cancer, predominantly EGFR, KRAS, BRAF, and other mutations like MET splicesite, ALK fusions, ROS1 fusions, MET fusions. So these all fusions which are, I think, now very redundantly used are, kind of targeted in non-small cell lung cancer. And we have approved drugs for all different types of EGFR mutations, HER2, ALK, ROS1, RET. And so I'll be discussing in more details coming further when we discuss the technology by which they are tested. So if we look at the recent NCCN guidelines, so it establishes that in advanced or metastatic disease, once the histological subtype is confirmed using the IHC markers, the adenocarcinoma has subtype has to undergo EGFR, ALK, KRAS, ROS1, BRAF, NTRK, MET exon 14, RET, and HER2 testing. This testing should be conducted as a part of broad molecular testing along with PDL1 testing. So this is predominantly guided mentioned in the NCCN guidelines. Also, there is a little a thing which I would like to highlight here, which is if there is insufficient tissue to allow the testing for all these markers, then a repeat biopsy or a plasma testing should be done. If these are not feasible, the treatment is guided by available results, and if unknown, then patients are treated though as they do not have any oncogenic driver mutation. So, irrespective of whether we can find out or if there is not a tissue there, in case of advanced cases, we can definitely come up to the plasma based testing, which I will be discussing further in the coming slides. So if we look at the principles of molecular and biomarker analysis and the testing methodologies which are mentioned in NCCN, I would like to highlight that it is recommended that wherever it is feasible, the testing should be done with a broad panel-based approach, most typically by NGS. And patients who in broad panel testing do not have identifiable driver mutations, especially who are never smokers, RNA-based NGS, if not already performed, should be performed to maximize the detection of fusion events. So why RNA-based NGS is the best method to detect the fusions, that is one particular point which I want to highlight here. And the reason why it is the best method for detecting detecting gene fusions is because of the first point is that it can detect the fusion partner, and the positions are also defined. So you can exactly find where the fusion is taking place between the two partners. Third thing is it identifies actively transcribed fusions, because we are doing it at the DNA, not at the DNA but at the mRNA level. So whatever fusions are actively transcribed, which are converted from DNA to transcribed from DNA to RNA, they will be identified by RNA based NGS. And also when we are doing DNA based NGS, we do not sometimes have the amplification or the targeted sequencing for the intronic regions. So if there is any fusion that is taking place in the intronic regions, that might be missed in the DNA based NGS. So RNA based NGS can avoid the tiling through the intronic regions. So definitely RNA based NGS is the optimal method for detecting all gene based fusions as compared to DNA based NGS or RT-PCR or FISH or IHCs, because these are not, if we look at IHC or FISH, they will not give you fusion partner, and fusion position will be unknown. So you will not know exactly with IHC whether it is fused with which part of the part of which gene. You might know that it is rearranged, but there could be false negatives. And FISH also has poor sensitivity for intrachromosomal rearrangement. So these things have to be taken into consideration when we are choosing the technology by which we are going to do the testing, because I believe that at the start of the treatment, these decisions are very critical because of the availability of the lung tissue which we are going to use for the testings. And this can really change the whole treatment of the patient. So that decision has to be taken in a very sane and very subtle manner, taking into consideration all the pros and cons of doing broad panel sequencing or going sequential testing of one gene after the other. So this is the latest algorithm of metastatic adenocarcinoma, which is being shared just, I think, in the Journal of Thoracic Oncology on 12th November itself. So this is the ISLC paper which has come out for specifically for biomarker testing in non-small cell lung cancer in Asia. So we do have contribution from major centers like PGI and Tata in this particular publication, and they have devised this algorithm for specifically Asian patients. So there are differences in terms of geographical arena of the patients, and it is also important, all the more important, to look at specific requirements of the specific regions as compared to just following the Western world. So this is a good move in terms of getting particular recommendations for the Asian patients. So as you can see, the algorithm says that metastatic adenocarcinoma patients should undergo EGFR, ALK, ROS1, PDL1 testing simultaneously by a single gene testing. If the genetic driver alteration is not detected, then they can go for multi-gene testing. And if it is detected, then approved target treatment could be done. If there is less of tissue, PDL1, we can do only PDL1. But if it is the tissue is available, test for PDL1 and perform multi-gene testing for actionable genetic alterations. And then along with PDL1, you can take a decision. So one thing is that you wait for the result and then start the treatment. The other thing is, if the patient's condition does not allow waiting for results, you follow the treatment guidelines for genetic driver negative disease, and when the report comes, you can change the treatment accordingly. So I have seen that this problem is generally faced when we start the patient condition allows, we can wait for the result before initiating the first line of treatment. So definitely, according to the local protocols, we can and condition of the patient, we can wait for the report, or we can just go for a negative disease, and then once the results are there, we can change the decision of the treatment accordingly. So this is a very important point for Asian population, which is being highlighted in this particular algorithm. Now coming to different alterations. So we have EGFR, for which there are three different types of alterations that are highlighted. These are all common alterations, which are exon 19 deletion, 21 mutations, exon 19 insertions. They are all responsive to first and second and third degree of receptor tyrosine kinase inhibitors. However, T790M shows resistance to first and second degree, and there are some uncommon mutations like L861Q, G79X, which are only responsive to afitinib and osimertinib. And exon 20 insertion are not responsive to any of the TKIs, except there is a new drug that has come up, which is avimentinib, which is earlier was in a subsequent therapy, but now I think it will be more frequently used as a first line itself. Then you have ALK-EML4, where you have series of ALK inhibitors, which is, I think, should be done by RNA-based sequencing that we just discussed. Then KRAS, ROS1, BRAF. So for all of them, we have specific drugs. And I think for KRAS, subsequent therapy of sotorasib has been indicated, but still it is not available in India. Coming to the other markers like NTRK123, though their possibility of percentage is very less, but you have available drugs called enterectinib and darotinib. Then MET exon 14 skipping mutations, amplifications can be detected by DNA-based NGS, and RNA-based NGS can improve the detection of amplifications. So that has to be taken into consideration. Then RET rearrangements, PDL1 testing by immunohistochemistry, HER2 mutations, amplifications, and overexpressions. So in case of lung cancer, HER2 mutations are more important. Amplifications are very rarely seen. And for HER2 mutations, we have trastuzumab and the coming up drugs, which are conjugates of trastuzumab. Then TMB is also widely accepted for immunotherapies where all other drivers are negative for the lung cancer patients. So one thing which needs to be highlighted for EGFR mutations is when we are doing exon 20 insertion by targeted PCR approach, it might lead to under detection of exon 20 insertion. So The prevalence of exon 20 insertion is almost 4 to 10% out of all the EGFR positivity percentage found in the all across. So NGS is preferred, and if T790M is detected in the absence of prior EGFR TKI therapy, then it could be a germline testing is to be indicated, because if the patient is not treated with any EGFR TKI and you get upfront T790M, this could be an indication of a somewhat hereditary component of EGFR driver mutated lung cancer. And so there are other drugs which other mutations which have to be screened. So a full length EGFR sequencing is definitely, all the exons should be covered by NGS. I think that gives the best diagnostic yield. Coming to ALK resistance mutations, so there are several mutations that can be detected by NGS after a patient is treated with ALK inhibitors like crizotinib. So after a point, the patient becomes resistant to the first line ALK inhibitors. Further on, selecting the next range of ALK inhibitors, we have to go for sequencing of the ALK domain and find out which mutations have come up or have taken place. There will be secondary ALK inhibitors occurring in the patients who are treated with ALK inhibitors already. And loratenib is the reversible third generation ALK and ROS1 inhibitor that can overcome multiple ALK resistant mutations and also penetrate the blood-brain barrier. So it has strong activity against the common mutations which are found in the ALK gene domain, like G1269A, one of the commonly found ALK resistance mutation. So coming to MET gene alterations, MET alterations are found in almost 3 to 4% patients with non-small cell lung cancer. They occur both in smokers and non-smokers, and uniquely exon 14 skipping mutation can be detected by NGS or hotspot testing, which leads to particularly usage of a FDA approved MET TKI called Capimetinib. And definitely detecting MET exon 14 skipping mutations is important in the start of the treatment. But in EGFR positive patients who are progressing on EGFR, MET amplification detection can be very important, because EGFR inhibitor resistance has been attributed to MET amplification, and almost 5 to 20% patients who are treated with the first generation EGFR TKIs might have as much as 25% positivity in those who progressed on third generation EGFR TKI. So MET amplification should be checked either with the FISH or NGS, and in patients who are undergoing EGFR TKI therapies. So then this is the next important gene, which is RET fusions. Almost 1 to 2% adenocarcinoma patients have RET fusions, and this is the most commonly occurring RET fusions, which is with the KIF5B exon 15 and RET exon 12. Typically, these mutations do not occur along with EGFR, ALK, ROS1, BRAF, or KRAS. So these mutations are exclusively found, they are mutually exclusive, and they are common in patients with history of non-smoking or light smoking, and also they have high prevalence of brain metastasis. Now coming to important mutation KRAS, I've already discussed all other points. One important point is that KRAS mutations are correlated with inflammatory tumor microenvironment, and definitely resulting in good response to immune checkpoint inhibitors. So then is the most important point of liquid biopsy. So the liquid biopsy in terms of advanced non-small cell lung cancer, patients where tumor sample is not available, we can go for a plasma first approach, and where it is available, it can help in the sequential diagnostics of MRD after the curative surgery, early detection of recurrence and progression of the disease. It has been found to be important in clinical scenarios like where patient already has no NGS mutation found, or in a patient where no further results from NGS was available due to low tissue quality. Their liquid biopsy can help. Uh, where there was insufficient sample and only few genes could be tested, there a secondary liquid biopsy can help. And also liquid biopsy can help where rebiopsy is not possible in case of patients who are progressing on the original line of therapy. So these are some cases. Others like progression on one first line of TKIs and progression of patient on the ALK based inhibitors. So on all these cases, liquid biopsy can help detect the mutations. And this is one example where we found, with the help of liquid biopsy, EGFR exon 20 insertion in a patient who was already treated with osimertinib, and after which we found the osimertinib resistance coming up. So liquid biopsy can help in terms of detecting the mutations and providing a monitoring kind of a way. So the current scenario, I think there are major barriers like cost, quality, access, awareness, and turnaround time. And particularly in Asia, the NSCLC is high, but there is less access to medicines and testing procedures. And a region specific approach should be implemented, because according to global survey, only half of the patients were given the testing. And with increasing number of genes, comprehensive profiling should be becoming a more efficient method at the time of initial assessment, because it can optimize the turnaround time for results, help sparing the tissue samples for other analysis. So that is the main point which I want to highlight, that we should focus on using the tissue very wisely and selecting the tests according to the cost, quality, and access, and awareness, and turnaround time. We should select the labs on basis of that. So that will be all. I would be happy to take any questions.
Yeah. Yes. I think question we will take at the end of the session. But thank you, Dr. Charu, for enlightening us about the NGS. And actually, the RNA NGS was not in my mind. I always used to order that. Please get the NGS done. And definitely getting a proper tissue and processing the lung tissue is, it's very tricky, and it's not always possible to get a good tissue, sufficient tissue to get the NGS done and all. But definitely NGS is now the need of the hour. And definitely for the fusion genes like ELK, red, MET, the RNA NGS should be preferred, and definitely, and with the good quality assurance lab. Yeah, thank you, Dr. Charu, for giving us a very enlightening talk on various genomic modality of lung cancer. Definitely, thank you so much. So
Thank you, sir.
so with moving forward, I would like to invite our friend and our colleague, Dr. Priyanshu Chaudhary, for our next topic of this session. Dr. Priyanshu, are you there, sir?
Yes, sir. Good evening.
Good evening. Good evening. Thank you, Priyanshu, for sparing your valuable time. So, Dr. Priyanshu Chaudhary will tell us what is the role of VEGF inhibitor in lung cancer. Although they are widely used, but what is the particular role of VEGF inhibitor in lung cancer? Please, over to you, Dr. Priyanshu. Yeah, please.
Thank you, sir, and I'll like to thank the organizers for giving me this opportunity. And yeah, are my slides visible and are they moving?
Yes.
Yeah. So my topic for today is the role of VEGF inhibitors in lung cancer in stage 4 metastatic non-small cell lung cancer. So we all know that angiogenesis is a key mediator in metastasis in every solid cancer, and the environmental factors like hypoxia, growth factors, pH, and hormonal factors, they increase the VEGFR levels. Also, the genes involved in tumorigenesis like P53, P73, they are also they also increase the VEGF level. Increased
Mhm.
VEGFR levels then lead to binding and activation of the receptor, which lead to increased survival, proliferation, migration, and angiogenesis in the tumors. So almost 30 years back, the studies showed that a higher microvascular density as well as a higher VEGF levels were associated with poor overall survival in lung cancer.
Mhm.
So we'll be dealing with these, trials, the phase 3 E4599 and the 2014 SEER database review, and the phase 3 Point Break trial, and the comparative analysis of the SAIL, AVAIL, and ARIES trial. So first of all, the ECOG 4599 and the NEGM publication, the paclitaxel combination alone or with bevacizumab for non-small cell lung cancer. So the study design was stage 3B or stage 4 non-squamous mNSCLC. The stratification variables were RT versus no RT, stage 3B or 4 versus recurrent disease, and patient who had brain metastasis, significant hemoptysis, inadequate organ function, and an ECOG performance status of more than 1 were excluded. The patient were randomized 1:1 into the chemotherapy alone arm, that is paclitaxel plus carboplatin versus paclitaxel plus carboplatin and bevacizumab at the dose of 15 mg per kg every 3 weekly till progression. No crossover to bevacizumab was permitted in the control arm. Baseline characteristics were again well matched. So coming to the efficacy, we see there was significant improvement in both progression-free survival and overall survival. The primary endpoint, which was overall survival, the median OS was significantly prolonged, 12.3 months versus 10.3 months. And the secondary endpoint, that is PFS, was prolonged. Median PFS was 6.2 months in the bevacizumab arm versus 4.5 months in the chemotherapy alone arm. Both of these were statistically significant. Coming to subgroup analysis, almost all the patient had derived benefits with the addition of bevacizumab to the chemotherapy arm, and irrespective of the subgroup in which they were. Coming to the toxicity, we all know hypertension and bleeding are common events with bevacizumab. But overall, if you see, the grade 3 toxicity were less than 1%, hypertension in 0.5%, as well as bleeding events in only 0.7%. So these, although theoretically significant, I think so in these large trials also there were very few patients who had grade 3 or 4 toxicity with bevacizumab. So this was again a real world retrospective cohort study comparison of survival and hospitalization rates between Medicare patient with advanced mNSCLC treated with bevacizumab, carboplatin, paclitaxel, and carboplatin, paclitaxel. So again, 1,700 patients were taken, 592 patients in the bevacizumab plus chemotherapy arm, and 1,114 patients with in the chemotherapy arm. And they were again stratified according to age, with less than 75 or more than 75. So if we see, there was a significant 2.1 month difference in overall survival between the chemotherapy arm in the bevacizumab plus chemotherapy arm versus the chemotherapy alone arm. The addition of bevacizumab was beneficial, and if we see, the addition of bevacizumab was beneficial in all the subgroups, whether they were less than 75 or more than 75, compared to chemotherapy alone. So the summary of these studies show that final results from E4599 showcase overall survival, a progression-free survival, as well as a response rate benefit with the addition of bevacizumab to paclitaxel plus carboplatin in the treatment of non-small cell lung cancer. And in the 2014 retrospective analysis of Medicare patient in the C database, the first line therapy with bevacizumab plus paclitaxel was associated with a longer survival and fewer hospitalization than chemotherapy alone. Now, this was a very important study, which was a point break study published in the JCO. It was a randomized phase 3 study of pemetrexed plus carboplatin and bevacizumab, followed by maintenance pemetrexed and bevacizumab versus paclitaxel plus carboplatin and bevacizumab, followed by maintenance bevacizumab in patients with stage 3B or 4 non-squamous non-small cell lung cancer. So this was a study design previously untreated stage 3B, stage 4 non-squamous mNSCLC, randomized 1:1 into bevacizumab plus pemcarb or bevacizumab plus paclitaxel. Again, the maintenance was with bevacizumab plus pemetrexed or bevacizumab alone till progression. The statistics analysis was in both the intention to treat population as well as the maintenance population. Baseline characteristics were again well matched. Now coming to the primary endpoint, which was the overall survival. So the overall survival, both in the intention to treatment arm as well as in the maintenance population arm, was similar between the two arms, that is pemcarb plus bev or paclitaxel plus bev. So there was no statistically significant difference between these two arms, whether in the overall intention to treat population or the maintenance population. However, when we come to the progression-free survival, the progression-free survival was prolonged in the pemetrexed carboplatin bevacizumab arm compared to the paclitaxel carboplatin bevacizumab arm, both in the intention to treat population as well as in the maintenance population. In the ITT population, the hazard ratio was 0.83, and the median PFS was 6 months versus 5.6. While in the maintenance population, it was 8.6 months median PFS versus 6.9, and which was again statistically significant. So although not a very big different numerically, but still it was significant. And now coming to the subgroup analysis, almost all the subgroup analysis subgroups achieved some form of benefit in the pemetrexed arm when it comes to progression-free survival, while the overall survival, it was not very significant. The overall response rates were again similar, 34% in the pemetrexed versus 33% in the paclitaxel, and the disease control rate again almost 66% and 70% in the pemetrexed and paclitaxel arm. Now coming to the toxicity, if the overall survival is not different, then there has to be some preference while choosing among the two, especially the non-squamous histology. So that was the difference was in the safety profile. So there was significantly more grade 3 or 4 anemia, thrombocytopenia, and fatigue in the pemetrexed carboplatin arm versus more of neutropenia, febrile neutropenia, sensory neuropathy, and alopecia in the paclitaxel, carboplatin, and bevacizumab arm. So if we have to choose among these, probably these side effects would guide us towards what to choose among these two. If the patient has a pre-existing neuropathy, then probably pemetrexed would be a better. And if the patient has significant other HB on the lower side and probably a history of thrombocytopenia, then maybe paclitaxel would be better. So to conclude, although PFS was significantly improved with pemcarb bev, there was no survival benefit observed against paclitaxel bev, and patients on pemcarb bev achieved a median OS of 17.7 months. And the study shows that choosing the most appropriate chemotherapy would be based on the specific patient clinical situation and tolerance to toxicities. So again, these were again the studies involving bevacizumab arm, the ARIES, SAIL, AVAIL, and E4599. Overall, if you see the median PFS similar around ranging between 6 to 8 months, and the median OS ranging between 13 to 15 months. And overall response rate slightly higher in the sales study, probably because of a different backbone chemotherapy. Then this was a meta-analysis of data from all these randomized controlled trial, and if we see there were improved outcome in the survival, overall survival with bevacizumab arm, if we see in this meta-analysis. So the NCCN 2022 guideline, we all know that in non-squamous histology, a combination of chemotherapy and immunotherapy is usually the preferred one these days. The immunotherapy partner can be pembro or atezo, but if there is any contraindication to PD-1 or PD-L1 inhibitors, or the most common practical situation is when the patient is not affordable, and we are having a driver negative disease. So in that situation, the addition of bevacizumab to the backbone of chemotherapy, whether it's a paclitaxel or pemetrexate plus a platinum, would be beneficial, and it's a category 1 indication in the NCCN guidelines. So bevacizumab is the only targeted therapy which can be considered affordable to patient with non-squamous, non-driver mutated mNSCLC regardless of the PD-L1 status. So the recommendation is chemotherapy plus Bev, and to continue maintenance therapy, which can be bevacizumab alone based on the E4599 trial, or Bev plus PEM based on the Point Break trial. Now again, NCCN also gives option of maintenance whether Bev alone or bevacizumab plus pemetrexate, which is indicated in non-squamous mNSCLC with a PS of 0 to 2. Now coming to the again NCCN guideline also says that if a bevacizumab biosimilar was initially used as a part of first-line combination therapy, the biosimilar should be continued as maintenance therapy in eligible patients. Most of our patients are usually on the biosimilar itself, and we have seen pretty decent results. Now coming to driver mutated, that is EGFR positive metastatic NSCLC. So these are the 3 trials we'll be studying. First was the retrospective analysis of real-world outcomes of 165 patients with EGFR exon 20 positive NSCLC in China receiving chemotherapy, EGFR TKI, or immune checkpoint inhibitor therapy. In patients who were treated with Bev plus chemotherapy in first line, the PFS was not significantly prolonged with the addition of Bev to chemotherapy in first line, but in patients who had second line treatment with Bev plus chemotherapy, the median PFS was significantly prolonged, 6 months versus 2.4 months. Now this was again a NEG026 trial, erlotinib plus bevacizumab versus erlotinib alone in patient with EGFR positive advanced non-squamous NSCLC. The study design was chemotherapy naive patient, non-squamous histology, PS of 0 to 2, stage 3B of 4, activating EGFR mutations, either exon 19 deletion or exon 21 L858R, and asymptomatic brain mets were allowed, but T790M mutated patients were excluded. The stratification factors were sex, stage, smoking status, EGFR mutation subtype, and the patient were randomized 1:1 to bevacizumab at a dose of 15 mg per kg every 3 weeks plus erlotinib 150 mg OD versus erlotinib alone. So if we see the PFS as assessed by the blinded independent review committee, it was again significantly prolonged, 16.9 months versus 13.3 months, healthy more than 3 months of PFS benefit with the addition of bevacizumab to erlotinib. Hazard ratio of 0.60 again, which is very impressive. Now, if we see according to the EGFR mutation subtype, there was a benefit in the exon 21 L858R mutation, but the same was not seen in exon 19 deletion. So this was again a Beverly trial. It was the trial of bevacizumab plus erlotinib versus erlotinib alone as first-line treatment of patients with EGFR mutated advanced non-squamous NSCLC. The study design was untreated non-squamous NSCLC with activating mutation of EGFR, stage 3B to 4, PS of 0 to 2, Control arm included EGF positive patient, alotinib alone arm with 150 milligram every day, while the experimental arm had alotinib at 150 mg OD plus bevacizumab 15 mg per kg every 21 days. So if we see, sorry, there was significantly increased progression-free survival with the addition of bevacizumab to alotinib, a median of 15.4 months versus 9.6 months in the investigator-assessed, while the blinded review showed median PFS of 14.8 versus 9.6 months. So both of these reviews showed that the PFS was significantly prolonged with the addition of bevacizumab arm. Unfortunately, the same could not be said for OS. The overall survival was not statistically significant, although it was numerically higher in the combination arm. If we see the subgroup analysis of PFS and overall survival, the PFS and overall survival was actually better in the patient who were former or current smoker with the addition of bevacizumab to alotinib. Again, overall, the objective response rates for both investigator assessed as well as blinded showed a higher response rate approaching around 70% in the alotinib plus bevacizumab arm compared to around 50% with the alotinib alone. The quality of life was, better or at least stable with the addition of bevacizumab arm with the addition of bevacizumab. So there was no significant difference found in any of the quality of life items according to the EORTC C30 LC13 score. Now coming to the side effects, again, hypertension and rash were, significantly higher in, the combination arm with a grade 3 toxicity of hypertension around 23.8% versus 5%, and rash in almost a third patients, 33% versus 16.5%. So these are, expected as toxicity, and there was also one death due to intracranial hemorrhage that was believed to be due to bevacizumab. So these are again the combination trials which are again going on with, the VEGF inhibitors, bevacizumab or ramucirumab, along with osimertinib, which are again going on. So to conclude, I would say that the benefit in the non-squamous mutation negative mNSCLC, the trials showed that benefit was there with bevacizumab induction as well as maintenance, and there was a slightly more benefit in less than 65 years of age and male patients. And the bevacizumab does not add very significantly to the toxicity, and addition of bevacizumab to EGFR positive patients helps in prolongation of PFS, especially in exon 20 patients along with chemotherapy, as well as in L858R exon 21 with the addition to the backbone of alotinib. In smokers also, there is a slightly higher benefit. So thank you, and I'll like the organizers to take the stage.
Yeah, thank you, Dr. Priyanshu, for giving us a wonderful talk on VEGF inhibitor. Definitely, vascular endothelial growth factor receptor, they play a very vital role in promoting the angiogenesis, and hence the inhibition of the angiogenesis definitely halt the progression of the tumor, and without adding the much toxicity, because bevacizumab, we are also using since our DM days, and although as much was feared that it leads to toxicity and all, we hardly see any patient with with significant proteinuria, or in my 5 to 7 years of experience, that I have seen only 1 or 2 cases of press, which has happened after the bevacizumab use, and that also we were not sure that it is induced by the bevacizumab. Otherwise, it's a very wonderful and safe drug. Thank you so much, Dr. Priyanshu, for sparing your valuable time.
Thank you, sir. Thank you.
Yeah. Now the next topic is yes. Now I would like to invite our next speaker of the evening, Dr. Sachin Gupta. He is an associate director at Max Hospital Mohali, and he's our senior and very valuable guide. And whenever we stuck to some cases, we always take his advice. So it's my pleasure and honor to invite Dr. Sachin Gupta. Uh, Hand over to you, sir. Over to you, sir. Dr. Sachin, are you there?
Yeah.
Yeah.
Thank you.
Thank you so much, sir. Thank you.
Thank
Yeah.
you so much, Deepak, for having me here today evening. Am I audible to you? Let me
Audible
share
and
my
visible both.
screen. Yeah. All right. So you can see my slides as well, right?
Yes, sir.
Let's go ahead. So the topic given to me is optimizing treatment for first-line non-small cell lung cancer and how atezolizumab is helping us in non-small cell lung cancer treatment. So this is a sponsored session by Roche. And without wasting any more time, I'll straight away come to the presentation. So we'll be discussing some background information, some evolving landscape, and we'll be primarily discussing three studies of atezolizumab, namely IMpower 110, 150, and 130. So non-small cell lung cancer, as we know, is a very important and very prevalent disease, and so it's more common than the small cell. Nearly 85% patients we are going to see are going to be non-small cell, and majority of them are going to be elderly, and majority of going to be advanced stage disease. And we all know in last few years on the usage of targeted therapies and now immunotherapy drugs have improved the prognosis of these patients. So this is how the treatment landscape has changed. So earlier we had only chemotherapy with us, but now we are using anti-angiogenesis, already discussed in the previous lecture, then targeted therapies, and now checkpoint inhibitors. So there is an unmet need in the treatment of patients with no actionable biomarkers. So this is the overall survival stratified by therapy. If we see these curves, so wherever targeted therapies are being used, the survivals are much better as compared to non-targeted chemotherapy versus only observation. So this is very obvious, and we all have experience of this thing. And if we see the molecular profiling on the right side, we see this pie chart where various kinds of mutations which we commonly encounter are written here. So KRAS mutations are very high, and hopefully we have some breakthrough in treatment of these mutations in next few years where the prognosis would improve. And of course we have EGFR, HER2, BRAF, ALK, where we have some interventions which can help us. Now coming to some global phase 3 studies of atezolizumab in the first lines. So we'll be discussing these trials. So let's briefly see what these trials tell us. So the first one is IMpower 110, so which was in squamous as well as non-squamous, where atezolizumab as monotherapy was compared with chemotherapy for squamous as well as non-squamous in PD-L1 selected patients. And IMpower 130, it was in non-squamous, where atezo plus nab-pacli and carbo were compared with only chemotherapy with nab-pacli carbo. And the question was that is a steroid-sparing chemotherapy regimen a better combination partner for atezolizumab? And then the IMpower 150, which is a very famous trial, ABCP regimen we call it. So where we answered that whether addition of atezolizumab to standard of care Bev plus pacli carbo adds to some clinical benefit, and is there improved clinical benefit if Bev is replaced by atezolizumab? So these questions were answered in this trial. Now coming to the first trial where monotherapy was compared with the chemotherapy in first line squamous as well as non-squamous. So this is the study design, randomized phase 3, and EGFR ALK negative patients. And if we see atezolizumab standard dose of 1200 3 weekly, and for non-squamous it was basically pemetrexed platinum, and for squamous it was gemcitabine with platinum. And for non-squamous pemetrexed maintenance was used, and for squamous only supportive care. And the primary endpoint was overall survival in wild type population. So the patients with any actionable mutations were excluded. And key secondary endpoint were PFS, response rates, duration of response. And so PD-L1 positivity was defined as, so the scoring system was used, and PD-L1 expression more than 1% on TC or IC. And so this was determined by ISC assay. Ventana SP142 assay was used in this particular trial. Now the prevalence of PD-L1 expression. So if we see the left side of this bar diagram, so TC3 or IC3 wild types, so more than 50% TC or more than 10% IC. So more than 1/3 patients were in this category, and prevalence of PD-L1 expression was similar between the treatment arms. So if we look at this, the middle one. And so the baseline characteristics were fairly matched. So between arm A and arm. So I'll request the audience to please mute their laptops. So if we see the age, the gender, and the race, and the tobacco use, so all these characteristics were fairly well matched in this. Now coming to the OS in TC3 IC3 population, so where this expression of PD-L1 was high, and we see the primary endpoint of OS in PD-L1 high subgroup was met, and the 6 months and 12 months OS, if we see the 12 months OS, nearly 65 months versus 50.6 months, and the HR of 0.59. So this trial shows that in high this PD-L1 expression, single agent atezolizumab is doing much better than the chemotherapy arm. And if we see the median OS, so this is 20 months versus 13.1 months, so which is a significant advancement. So OS in key subgroups, if we see across majority of subgroups, so according to PS, squamous versus non-squamous, and especially the tobacco users, white as well as Asian, males and females. So in all the subgroups, so in very elderly, so there were few patients, so there it is not showing benefit, but otherwise in all the subgroups, there is good significant benefit seen. And if it's the subsequent treatment, the proportion of patients who receive subsequent chemotherapy or targeted therapy was similar across the PD-L1 subgroup. And in arm B, if we see immunotherapy, a lot of patients subsequently received immunotherapy here. So this is median PFS 8.1 versus 5 months. So confirmed overall response rates were also higher in this. And if we see the safety profile, so this was again favorable as compared to the chemotherapy. So there were known grade 3-4 toxicity as we expect from immunotherapy drugs. So some hypothyroidism, pruritus, increased AST, but other parameters were much better. The toxicity was higher in the chemotherapy. So to summarize, atezolizumab represents a promising first-line treatment option in patients with PD-L1 high non-small cell lung cancer. And this is a positive study that demonstrated statistically significant and clinically meaningful improvement in OS in TC3 IC3 wild type population versus platinum-based chemotherapy with a hazard ratio of 0.59. And the safety profile was consistent with the prior observations, no new extra safety signals. And atezo has favorable safety profile compared with chemotherapy. And so the patient with atezo had a longer treatment exposure than with chemotherapy. So now coming to IM power 150, which is in non-squamous, non-small cell lung cancer. So this is a phase 3 study of atezo plus chemo and Bev in first line advanced non-small cell lung cancer. Now the clinical question here is, does addition of atezo to standard of care Bev plus Pecli plus carbo adds to clinical benefit, and is there improved clinical benefit if Bev is replaced by atezo? So stage 4 non-squamous chemotherapy naive, and so the stratification is according to gender, PD-L1 expression, and liver metastasis. And so there are 3 arms: atezo with chemo, atezo, chemo plus Bev, and chemo plus Bev. And in maintenance, atezo versus atezo Bev, or only Bev was allowed. And the co-primary endpoints was PFS and OS in intention to treat wild type. Now atezo, so there is some some background information here. So what is happening with the usage of these drugs? So Bev is inhibiting the VEGF mediated suppression of dendritic cell maturation, enabling the efficient priming and activation of T cell response. And Bev normalizes the tumor vasculature, resulting in increased infiltration of T cells into the tumor, and this decreases the activity of MDSCs and Treg cells and enables reprogramming of the tumor microenvironment. Now, atezo's ability to restore anti-cancer immunity through T cell mediated cancer cell killing is further enhanced through Bev VEGF mediated immunomodulatory effects. And chemotherapy induced immunogenic cell death can trigger the release of tumor antigens, so which will lead to more antigenicity and response to, by the bevacizumab as well as the immunotherapy drugs. So these are the baseline characteristics. So median age nearly 63 years, and about 60% patients were male, and good PS, and never smokers were around 20%, liver mets nearly 13%, EGFR mutation positive number was around 11%, ALK 2%, KRAS 29%, and so PD-L1 expression, so TC123 or IC123 was 53, and TC0, IC0 nearly about 48-50% here. Now there was significant OS benefit with the addition of atezo in the ITT wild type arm. So where the mutations, the actionable mutations were not there. So ITT, intention to treat wild type. Now here we see that arm B, which is atezo, Bev, and chemotherapy. If we see the OS, so 12, 18, and 24 months. So in all 3 parameters, if we see 24 months OS, 43% versus 34, and HR of 0.8, and median OS 19.5 versus 14.7. So nearly 4.5 months additional OS. And overall response rate and duration of response were also improved in the intention to treat. So if we see this bluish bar, arm B, so which is higher in across the intention to treat, PD-L1 high, PD-L1 low, as well as PD-L1 negative. So in all these 4 stratifications, the arm B is showing better median duration of response here. And OS benefit was also observed across PD-L1 subgroups in wild type population. So in PD-L1 high, hazard ratio of 0.7, 25 months versus 15. In PD-L1 low, 20 versus 16. And in negative, again 17 versus 14. So irrespective of PD-L1 status, there was benefit of addition of atezolizumab. And if we see the subgroup stratification in EGFR positive, after EGFR TKIs have been used, so if we see this lower half of this EGFR mutation or ALK, EGFR mutation sensitizing, and so meaningful PFS benefit was observed for arm B versus arm C in patients with EGFR mutation positive. And so the curves are diverging a little later. If we see this hazard ratio of 0.59, median this 9.7 versus 6.1 months. So this is the PFS benefit. And OS benefit in patients with the EGFR mutations. So arm B versus arm C. Here again 29 months versus 18 and 19 versus so. And if you see arm A versus arm C, there is no benefit was observed here. So arm B is clearly showing some more benefit here. And overall response rate and duration of response were also improved with Bev atezolizumab chemotherapy. And there was nearly 6% complete remission also. And median duration of response 11 versus 4.7. And if we see the liver metastasis, here again we see there is benefit and clinically meaningful survival benefit with this regimen. And liver metastasis, as we know, is again one of the negative prognostic factor. And so OS benefit was observed in liver mets, 13 versus 9. And if we see A versus C, then there is hardly any difference there. All right. So addition of Bev to atezo plus chemo improved overall response rate and duration of response in liver metastasis also. So median duration of response 10.7 versus 4.6 and response rate 60 versus 40. And in bulky, so in high disease versus low disease burden. So this is SLD is sum of the longest diameter and the number of metastasis site. So here again, according to high versus low. So median OS in high disease burden as well as low disease burden. Again, the arm B is showing higher benefit here. More OS and more response rates as well. All right. So this is the safety data. Again, no new additional. The safety profile was similar to this. And as we expect with usage of chemotherapy as well as immunotherapy drugs. So I'm not going to details of that. So to conclude, IMpower 150 is a positive study in first-line non-squamous lung cancer with statistically significant and meaningful improvement in both the co-primary endpoints of OS and PFS. And this benefit was observed in key subgroups of patients with EGFR, ALK alterations, and liver mets with the addition of Bev to atezo chemo. And atezo in combination with chemo Bev is well tolerated and safety profile is consistent with known risks. And additional patient characteristics beyond PD-L1 expression may be considered when making this treatment decision for non-squamous non-small cell lung cancer patients. And so coming to the bottom of this, the third line, atezo Bev pegcilcarbo nearly doubled PFS benefit at 12 months, and 12-month PFS was 38% versus 20% with Bev pegcilcarbo alone. And I'll just skip this slide and come to the third trial here, IMpower 130, which is for again for non-squamous non-small cell lung cancer. This is phase 3 study, carbo napecli with or without atezo in first-line advanced non-small cell lung cancer. And so the goal of this combination is to create a more favorable environment to maximize the potential of immune system to eliminate the cancer. So chemotherapy induced immunogenic cell death can trigger release of tumor antigens, and atezo has the ability to restore anti-cancer immunity by preventing T cell deactivation. So this is the trial here, and chemo naive patient stage 4 non-small cell non-squamous, and stratification according to gender, PDL1 and liver mets again. Atezo, napacli, carbo, followed by maintenance atezo versus napacli, carbo, followed by maintenance pemetrexed. And so this switch maintenance was permitted. And atezo was given until PD or loss of clinical benefit, and pemetrex until PD. These are the baseline characteristics, which are again quite well matched in both the arms. And about 15% patients had liver metastasis, and about 59% patients were male gender. So investigator assessed PFS was significantly improved with addition of atezo to nab-pacli and carbo in intention to treat wild type. And if we see 6 months and 12 months PFS, and 56 versus 42 and 29 versus 14. So this is landmark 12-month PFS doubling with the addition of teaser 2, nab-pacli and carbo, HR of 0.64, and we can see these curves which are showing median 7 months versus 5.5 months this PFS. And OS was significantly improved with the addition of atezo. So OS HR of 0.79, 18.6 versus nearly 14 months. So again, about 4.5 months improvement in OS we can see here. And OS benefit was observed across clinically relevant subgroups in majority of these cases. And the OS benefit was again seen in favor of atezolizumab. But no PFS OS benefit was observed over chemotherapy alone in patients with EGFR ALK positive disease. So this is investigator assessed PFS and OS where there is hardly any difference here in EGFR ALK patients. And overall response rate and duration of response were improved in arm A versus arm B. Here we can see the blue bar is higher with more response rates, slightly more CR, and of course more PR. 8.4 versus 6.6 months. And the tezo-carbo nab-pacli was well tolerated, and again safety, I'm not going into detail of this. And so expected safety data again here. And the conclusions of IM Power 130. So this is a positive phase 3 study for atezo in first line, and providing an alternative chemoimmunotherapy plus so CIT plus chemotherapy regimen for patients with chemotherapy naive non-small cell, and clinically statistically significant and relevant OS benefit when this was atezo was added to chemo, and PFS benefit and higher overall response rates with addition of atezo, and OS PFS benefit across subgroups except with EGFR ALK positive patients and with liver mets here, and supporting use of IM Power 150 regimen in those patients. So this suggests that wherever we have situation where EGFR ALK mutation patients are progressing with over TKI after usage of TKIs, we can use this regimen and we can get some responses here, but we need to use bevacizumab also in these patients. And the tezo plus chemo had a safety profile consistent with adverse events with the associated with single agent therapy. No new safety signals were identified here. I think this is all in the presentation here. And over to Dr. Deepak.
Yeah, thank you so much, sir, for giving us a very uh, very good talk on atezolizumab. Now, there is no doubt that immuno-oncology has become a standard of care, and we are all of us are using the first line ABTB protocol very quite often, and without much adding to the toxicity, and without the irrespective of the PDL1 status, and people are doing quite well. Without adding to their toxicity, without adding to any toxicity. Thank you so much, sir, and. Now move to our last session. Ayush, let's start the panel discussion now. Mhm.
Upcoming session is sponsored by our academic partner INTAS, and that is a panel discussion, management of mNSCLC panel. And to moderate the panel, I would like to invite Dr. Deepak Singla, sir, and to invite the panelist also. Over to you, sir.
Yeah, thank you so much, Ekta. And now I know it's dinner time, so I won't take much time. So for the panel discussion, I would like to invite our panelists. First of all, uh, are you sure that Dr. Mukesh Bansal is there, right?
Yes, sir. Mukesh Bansal is there.
So I would like to invite Dr. Mukesh Bansal, who is a consultant, who is a consultant medical oncologist at our in Panchkula at Alchemist Hospital. Welcome to Dr. Mukesh Bansal, and welcome to the Panchkula as well. Dr. Mukesh Bansal,
Yeah,
Dr. Mukesh, are you there?
good evening. Yeah, good evening, sir. I'm there. Thank you.
Okay, and I would like to invite our colleague Dr. Kanika Sharma. She's a associate consultant at Max Super Specialty Hospital, Mohali. Dr. Kanika, are you there?
Yes, sir. Good evening, sir.
Yeah, thank you. Thank you for joining us. And another is I would like to invite our molecular specialist from MedGenome Lab, Dr. Charu Bahel, and who is a scientific lead in MedGenome. Welcome, Dr. Charu.
Thank you, sir.
Ayush, who else is there?
Ankur Punia, sir, is there, sir?
Yes, and I would like to invite Dr. Ankur Punia, who is assistant professor at Mahatma Gandhi Hospital at Jaipur. So he's our junior and colleague, Dr. Ankur Punia. Ankur, are you there?
Yes, sir.
Yeah, thank you for joining, Ankur. You have changed a little bit, Hana?
And sir, we can request Dr. Sachin also for the panel.
Sir, Dr. Sachin, sir, please give us 10 minutes more, sir. Yeah, please. Hello, Dr. Sachin. I think sir is also there. I can see his name. Dr. Sachin, sir, unmute yourself, sir, please. Hello. I think you can call
Sir,
him.
we'll call. Yeah, sir, we'll call and
Yeah, please share the slides, please. So it's 8 o'clock already. It's 8:10. Okay. Yeah. Can you share the slide, please, Ayush?
Yes, sir. I'm just sharing.
Mm. Yes, I mean these slides were, given to us by AstraZeneca, and let's start. Today's topic is management of EGFR mutant non-small cell lung cancer, and how do we treat these patients? And let's see. Move on the slide, please. First slide, please. Here is a patient, female, 65-year-old female with left pleuritic chest pain for last 1 month, and CT was ordered, which shows a left lower lobe mass of 5.5 centimeter, invades the pleura, sub-centimeter right paratracheal and left hilar lymph nodes, and left pleural thickening and effusion. So histology report are awaited. So provisional diagnosis is, CA lung, left lower lobe, clinically T3 and 3M1, left pleural metastasis, and PDL expression is 55%. Oncogenic drive mutation is results are awaited. So Dr. Kanika, what is the further any other testing would you like to do in this case?
So I'm assuming, a non-smoker female. So I would still like to do the mutation testing in this patient.
It is done. The results are awaited. As we know that.
So if the patient is symptomatic, then since it is proven, I think histology also that cancer is there. I would start with the Yeah, I will start with the first cycle of the chemotherapy, and then depending on the further result, I can, from the second cycle, I'll shift to the other line of therapy.
Okay, right. Ankur, what about you?
Yeah, I agree. Same, sir. It depends on if
Yes.
patient is too much symptomatic, I'll just start chemotherapy and wait for the genetic test to come back, whether to decide to whether to add immunotherapy or some other thing.
Some other thing. Okay. No, immunotherapy, you can still add PDL1 is 55%.
It's a female patient, sir, so there is still some doubt whether she might have some genetic mutation, and in those patients there are less chance of immunotherapy working. So I'll wait till the results are there.
Okay, right. Thank you. I think Dr. Mukesh will also agree for the same.
Yes, sir. I will start with the first cycle of the chemotherapy and wait for the oncogenic mutation testing report.
Yes. Dr. Charu? Yes.
Yes, sir.
Okay. Next slide, please, Ayush. So now coming. So which site would you choose for the tissue biopsy? If the primary lung biopsy is not accessible, are you okay with the metastatic site biopsy, and or would you like to go for a upfront biopsy? So please, my question is to Dr. Mukesh. Mukesh.
Sir, I will go with the metastatic site biopsy if it is possible.
Mm, if it is, Dr. Charu, I mean, is there any difference in the results of, whether we take the sample from metastatic site or the primary site? Is there is any disparity in the results?
So ideally, since the cells have migrated from the primary site to the metastatic site, do not see much of the changes, but there could be tumor heterogeneity. So, in terms of having that gap, once the results are out from the metastatic site, if we do not get any mutations or alterations, I think we can go for liquid biopsy upfront, because that will give us full map of the tumor heterogeneity also. So there might be some cells which have particular mutations and others not having it. If the results are negative, then we can go for liquid biopsy upfront with the metastatic site biopsy.
Metastatic site
If the
biopsy.
primary site is not accessible at all. So,
Okay. You mean to say if we are taking the sample from the metastatic site, the two samples should go, one in the liquid form and another one is from the metastatic
we
site.
can do parallel testing also, yes. So that will give us the best, that is the best possible scenario. But if the patient is
And
not affording that kind of testing, then we can first do the metastatic site testing, and if it comes negative, then we can do liquid biopsy.
Okay, affordability is not the concern actually. We have all type of
Yeah, so then parallelly we can do both the tests, so that will give us full clarity that we are not missing on any mutations.
Okay, do you agree on that, Dr. Kanika? What are you doing in your practice? And Dr. Ankur?
Just considering this case, since the metastatic site is pleural effusion only, and the fluid does not come positive very frequently, so anyway, I would like to do the site is accessible from the lung only. Because with the liquid biopsy, anyway, if it's come negative, then also it's not definitive. We again have to go for a tissue based biopsy.
No, I mean, we are not substituting any tissue biopsies. Tissue biopsy has to be done, whether it is accessible or not, right? Now
Yeah.
the question is, if you are taking a tissue from the metastatic side, so would you like to do a liquid biopsy as well? Because it's very irritating for the patient, after waiting for few days, and then we say that it is not conclusive, or mutations are not coming in favor of you. Let's send the liquid biopsy, and assuming that patient is affordable, Ankur,
Yes.
right? Suppose the patient is Rajasthan government beneficiary coming to you, and our patient is ECHS beneficiary, and ECHS says there is no problem. So would you like to send the NGS on the front line?
So not NGS, but in this case, definitely EGFR ALK also we just send upfront from the liquid biopsy, EGFR, and then wait for the lung biopsy as well. Not upfront NGS, but the other panels that are available for the common mutations that we are doing in all the lung cancer patients.
Okay, you mean to say EGFR, ALK, and at the best,
ROS, yeah.
ROS, all three. Ankur, do you agree for the same?
A patient who can, has all the options in the there is no financial constraint. I will go for NGS upfront. And nowadays, I
Yes.
think NGS has become much more easier with all the coupons by the companies. It takes around 5-6 thousand, and we can get a broader panel. And most of the genes are
Right.
covered by that. So I prefer nowadays to do a NGS rather
Yes.
than to send for an individual gene and individual markers.
And wasting the tissue, because tissue is always a problem in the lung,
Yes. So
Dr. Mukesh, this like assuming that
If
patient has no financial burden, so what is the harm in sending the NGS panel upfront, that to RNA NGS panel? Okay, because she's a female, she's a non-smoker. Okay, what do you think, I mean, is there any
if
harm of sending
if
NGS
the
panel
if the
upfront?
affordability is not an issue, yes, sir, then we should be sending the NGS panel. At least our practice has moved with the Dr. Ankur has told like the rates have come cheaper with the coupons the companies are providing. So if the
Right.
affordability is not an issue, we will be sending the NGS.
Right. Dr. Kanika, now you agree a little bit? I mean,
Yes, sir, I actually agree. But yeah, so the broad NGS, no, but the coupons that are available that are covering 9 to 10 genes, yeah, that we are doing upfront also.
yeah, I mean, that's right. But Charu, what do you advise us to the clinician to, to not to miss the fusion genes also? Okay,
Yes, yes.
as
So
we know that
the
the ret mat mutation, any these mutation which comes to generally to the non-smokers, okay,
yes, sir.
and to the young patients, okay.
Yes,
Chalo,
sir.
as the patient is 65, but she's a non-smoker. So, would
Right,
you
right.
like to guide us, whether we should RNA or DNA? Because tissue is
So
always a problem. So we,
basically, the panels which are which I think Dr. Ankur also mentioned, so that the even those coupon panels have DNA plus RNA based sequencing, which is I think which AstraZeneca is providing, and the testing is done with MedGenome. So those
Mhm.
coupons have both DNA plus RNA based sequencing, DNA for the point mutations like EGFR, HER2 and KRAS, and for RET, MET, and NTRK and ALK, we are doing it by RNA based fusion. So that 12 gene panel also covers all the point mutations and the fusions by the good technology DNA and RNA sequencing. So it's a composite panel only. So I think you can go ahead with that in this particular case.
So we have to mention that we have to get the RNA NGS. So it will
Uh,
cover the both.
The DNA plus
Okay.
RNA NGS, yes, sir. So it
Okay.
covers the both. So that
Okay.
AZ panel with the MedGenome, which AstraZeneca is providing, that coupon that has RNA plus DNA NGS, sir.
Okay. Okay. Okay.
Yes.
Right. Next slide, please. Ayush, next slide. Please move the next slide, please. Ayush. Okay. 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 Really. Okay. So, what are the routine practice for the staging workup? Dr. Mukesh, my question is to you.
Sir, PET CT and
PET CT.
MRI, yeah, and MRI brain. If it is like
Upfront.
CT is showing, yeah, upfront. If CT is showing pleural effusion, so we must rule out brain met site.
Okay, right, right. If the CT was not showing the pleural effusion, still you would like to do the brain MRI or not?
So that depends on the exact case. As the guidelines now recommend the stage 2 or 3 onwards, we should be doing MRI brain
Yeah,
upfront.
upfront.
But depending on the financial condition of the patient and the symptomatic status, if there is suspicion, we can go for that. But PET CT most likely yes, because finances came out to be almost same to the CCT test and whole abdomen.
Right. Although NCCN say that we should get the CT chest, abdomen, and
Yes.
pelvis done as a part of, but is to be practical. I mean, PET CT is the right choice for the staging workup. My other panelists will agree with me or not? Dr. Kanika, Dr.
Yes, sir.
Ankur, ठीक है?
yeah.
ठीक है. So brain MRI, we have to also get it done, whether the patient is symptomatic or asymptomatic, irrespective of that we have to get it done. I mean, according to the NCCN guideline, right? We have to at least offer to the patient that we should get it done. Next slide, please, Ayush. Would you like to scan the brain or not? Yes.
Yes.
Yes. Okay. Okay. Next slide, please. Which are the patients? These are the patients. I'm in stage 4A, M1B. Who has, if not previously done brain MRI with the contrast, they are having a performance status of 0 to 1 limited metastatic cream. So we should get the MRI done. Okay. Afterward treatment part we will discuss later. Next slide, please. If MRI is not possible, then CT of the head with contrast also we can get it done. Right. Next slide. So this is the coming back to our case. So biopsy came out to be adenocarcinoma, classical TTF positive nepsin A. Diagnosis adenocarcinoma lung, left lower lobe, clinically T3, M3, M1, left pleural metastasis, PDL expression 55, oncogene driver testing, EGFR exon deletion positive. So how do you want to proceed with this patient? Ankur, I will ask from you. You
The
are
best,
you are from a medical college and academic post. So please tell us that
so
how
the
do you
best
want?
option for this patient will be osimertinib. His cost is not the issue.
Mm.
Osimertinib has sort of the best results and one of the most safest drug to use. So I'll prefer to give osimertinib upfront.
Yes, yes, yes. Dr. Kanika, you agree with that?
Yes, sir.
Right. Okay. And Mukesh?
Yes, sir. Osimertinib if there is no financial constraint.
Okay, if there is no financial constraint, but our offer, we should be offering that osimertinib. Okay, right. Next slide, Ayush. Okay, why not immunotherapy? It is 55% positive.
So we need
Okay, okay. Chalo, leave it there already. So, what do you prefer? Chemo or immunotherapy, chemo immuno, or you prefer this awesome TKI alone, or TKI plus chemo, or TKI plus VEGF inhibitors? Osimertinib, everybody agrees. Only TKI.
Yes, sir. Only
Yes.
TK.
for a patient who can take, then yes, only TKI. If he cannot afford osimertinib, then maybe TKI plus chemotherapy.
TKI plus chemotherapy. Okay, which TKI then you will choose with chemotherapy?
Jeftinib. Jeftinib.
Jefferton. Okay, yeah, it's okay. Next slide, please. So okay, so everybody will agree that everybody wants to start the TKI, the Tegriso, which I think generics are not available, and the standard is Tegriso only. If the affordability is not a concern, right? Uh, Starting so we are not preferring the IO in spite of having the PDL1 55%, right? Ankur has rightly said that he would like to wait even for the get the mutation results comes. Next slide, please. Next slide. Yes. So what are the would PDL1 result of 55% favor in starting of immunotherapy in this patient? Role of what is the role of immune check inhibitor in EGFR mutated stage 4 non-small cell carcinoma tumor? Yeah, it's a very well-known effect that tumors with EGFR mutation, they generally do not respond well to the anti-PDL1 or anti-PDL1 checkpoint inhibitors. Even in the second line chemotherapy or chemotherapy plus IO is preferred over the immunotherapy monotherapy. Right. Next slide, please. So coming back to original case, this patient is 65-year-old female, adenocarcinoma, left lower lobe, stage 4A, left pleural metastasis, PDL1 55%, EGFR exon 90 deletion, mutation positive. So what would you prefer, sister? Here, have you come to go to next slide, please, Ayush. This slide was already repeated. Yes. So which would EGFR mutation favoring a starting TKI? Yes. So osimertinib, according to the NCCN guideline, also is the first line of therapy. So we can start the generation 2, generation 3rd TKI upfront. So we will discuss further why we are starting that. Next slide, please. So go to previous one. Yeah. previous one, yes. Preferred first line therapy is osimertinib because osimertinib has been given a preferred recommendation in the first line of treatment. We will see that why it has been given the first line. Uh, next slide, please. What are the consideration when we choose the first line treatment option EGFR mutation lung cancer patient? So so which TK? Why not generation one, second? Okay, why are you jumping upon? We are on the directly on the osimertinib. Dr. Kanika, why?
So, because if the cost is not a constraint, then considering the data that is available, osimertinib, it has the highest, longest PFS as compared to all the others. So, when we see jeftinib or lortinib, it's around 9 to 11 months. Whereas with this, it is around 19.8 months, almost double with the other agents. So even with the combination also, it is more with osimertinib if we are even using jeftinib. So.
Okay, right. So when we are choosing the first line treatment option, we always look for the safety profile, overall survival, and progression-free survival, because sometimes our patient may not give a second chance to switch to the second line generation or third line generation. So we want to use that such molecule which is having the maximum benefit and the very good safety profile if the cost is not a constraint. Next slide, please. Very right. So we can comparison from the PFS, Kaplan-Meier comparison, Lux Lung 7, Archer 1050, Flora trial. All these three graphs, the immediate separation of the curve has started with the use of the osimertinib. Okay, osimertinib, and the curves remain separated till the end of the but till the very much of the end. So definitely it has a progression-free survival benefit on the this as comparatively to the erlotinib, afatinib, or as comparatively to decmotinib versus. Next slide, please. Next slide, please. Yeah, please. Next slide, please. So, so there are head-to-head studies which show a second and third line generation EGFR TKI provide a significant longer progression-free survival as comparatively to the first generation TKI, whether it is erlotinib versus gefitinib. We can see the blue bar of the erlotinib is 13 months versus 10 months, and afatinib versus gefitinib, it is 11 versus 9, and most important is osimertinib plus versus erlotinib. It is as Dr. Kanika has rightly said, that there is a clear cut 18.9 months versus 10.2 versus erlotinib. In the Flora trial, in the phase 3 trial, is approximately doubling the PFS time. Next slide, please. So PFS is a direct measure of the drug's benefit. Yes, immediate separation of the PFS Kaplan-Meier curve in the Flora study. Osimertinib provided unprecedented improvement in the PFS 18.9 months, hazard ratio of 0.06 in the Flora trial. Next slide, please. So PFS summary of first line treatment in metastatic EGFR non-small cell lung cancer. So overall response rate in osimertinib is 80% with the median PFS was 18.9 months. Next slide, please. So overall survival outcome for the first line treatment in metastatic EGFR non-small cell lung cancer, it is very much significant. It is 13.86, 38.6 months, which is very significant. And as compared to decmotinib, which is 34.1, which is not significant. Okay, so I mean, it is not only give us the PFS advantage, as well as it is also giving us the median overall survival, more than 3 years. Next slide, please. So, but this is for overall response or not. So again, the overall survival, yeah. So, so median overall survival, which was seen, in the Flora study, in the EGFR TKI has been translated into PFS to a significant overall survival benefit, 38.6 versus 31.2 months. 62% of the patients in the Flora trial were Asian, right? So what is the average prevalence of EGFR mutation you are getting in your day-to-day practice? Like because it's a now a getting a driver mutation done is a very standard of care these days. So what is the percentage of getting EGFR mutation? Kanika, I mean, because yours is a high volume center, and Ankur.
So around 20-25% we are getting EGFR mutation actually.
And okay, 20-25%. So you mean to say every fourth sample is coming positive about for the EGFR, right?
Yeah.
This Ankur, what about you?
Yeah, I'll say the same, sir. Because say we receive most of the patients which are usually from rural background and not, generally women, mostly men. So we don't have that high 20, I'll say 20 to say similar percentage.
Okay, Mukesh, can you share some experience from Bathinda? You must have done a very lot of EGFR mutation testing.
Around
In
same,
age.
sir, around similar, sir. I will say 20-25%, maybe 20.
Okay. My experience is not very good. I mean, my patients come in, they are all mutation negative. It's a very long time since I've seen any patient with EGFR mutation. Okay, next slide, please. So coming to, when we are choosing our TKI, we always see for the OS, PFS, now coming to the, and affordability of course, and now coming to the safety profile. Now our TKI should be safe. So next slide, please. So what is the, I mean, you must be having some patients on the osimertinib. Any toxicity did you, came clinically, I mean, in your practice, day-to-day practice?
It's usually well tolerated.
Well,
Mostly, there was one with the diarrhea they had, but after stopping for 4-5 days, actually it resolved. So otherwise, it does not need frequent stopping or interruption of the treatment.
Right. If we see the data also, adverse event grade 3 more than 3 was only 34% comparative to the Archer study. It was 63, and Lux Lung it was 49%. And skin toxicity was only 1%, and diarrhea was only 3%, which is more than the grade 3, and stomatitis was only 1%. Whether in the remaining Lux and Archer, it was quite significant. So osimertinib, according to this data, is very much well tolerated. Yeah. So any cardiac issue have you came across any time? Any QTC and all thing? No.
No, sir.
Okay. Please. Next slide, please. So, safety summary of first-line treatment in metastatic EGFR non-small lung cancer. Among the EGFR TKI, second-generation TKI have unfavorable tolerability profile. Grade 3 and above adverse events are much higher with dacmatinib and afatinib. EGFR TKI combination therapy are also associated with significant higher grade 3 or above adverse event compared to EGFR TKI alone. Next slide, please. Ayush, next slide. Ayush has gone for dinner. Ayush. So so key safety summary. Archer comparatively to the, I think they have Archer 1050 and plus Flora clinical profile. So any advancement leading to the dose reduction, it was quite high with the dacmatinib and 66%, while it was 2.9% in the Flora study, which is quite significant. Even if comparatively to the gefitinib also, it was 8% versus 2.9%, so much less than 50%. And permanent discontinuation was only seen in 13% in with the osimertinib, while it was seen in the it was only 10% with the Arca study, and with the gefitinib was 7%. And any advancement leading to the death, it was 10%. It was only 2% with the Flora study. So next slide, please. So again, we had discussed that dose reduction is Archer is very high. Serious advancement is Archer is dacmatinib is 27% versus 4%, and advancement leading to death is 10% compared to 2%. So I mean there is a quite significant difference in all the adverse event. But however, permanent discontinuation was slightly higher in the osimertinib. Next slide, please. So dose reduction, so depending upon the adverse events, duration and severity, the dose modification of second generation TKIs may be necessary to improve the tolerability. So dose reduction due to the adverse event, The second generation EGFR TKI ifatinib may have been shown to frequently cause of advancement that has required a dose reduction. So we have already discussed that dose reduction was, it was very less in Flora study as comparatively to the Lux as well as in Archer. It was in Lux study, when the afatinib was comparatively with gefitinib, it was 52% versus 1.9%. In Archer also it was 66%. It was in Flora, it was only and only 4% only. Next slide, please. Okay. So dose reduction due to the advancement, okay, were depending upon the advancement duration and severity, dose modification of second generation TKI may be necessary to improve the tolerability. So these data suggest that dacmotinib is often intolerable at the starting dose of 45 mg per day. Have anybody has experience with dacmotinib? I don't have. Like, anybody has used that?
I have one patient on dacomertinib. She was not able to afford osimertinib, and the second drug which have a better PFS. So we have, but fortunately, seeing all those adverse effects, she is tolerating 45 mg per day. We have not, and now it's 8th month she's on treatment. So in interval also the good response is there, and she's continuing on dacomertinib actually.
Okay. I am. Ankur, what about you?
Sir, I have 1 or 2 patients, but both the patient I had to reduce the dose because of toxicity, particularly because of diarrhea.
And because of diarrhea, diarrhea was a troublesome.
Yes.
Okay. So you permanently discontinue that diarrhea.
No,
What was
sir, I
the
reduced with reduced doses. I was able to manage, sir.
Okay, you were able to. And Dr. Mukesh, any experience with dacmotinib?
No, sir, not much experience.
Not much experience. Okay, next slide, please. Safety post. Okay, next slide, please. Next slide. So again, the safety profile. So coming to the diarrhea, diarrhea with osimertinib was only 2.2%. QTC prolongation was also 2.2%. Fatigue was 1.4%, which was grade 3. Okay, and so it is in overall it is well tolerated. Next slide, please. However, even after the dose reduction, yeah. So dose reduction, which was as Ankur. Okay, your patient is tolerating 45 mg, Dr. Kanika, right?
Yes, sir.
Okay, strong lady. I mean, female patient, right?
Huh?
That patient is female patient.
So female patient, actually, she frequently travels abroad also. So every 3 months she is coming for follow up, and actually she is tolerating very well in this treatment.
Okay. Right. Okay. Do you give some preventive, some supplements to
So we mentioned that this is one of the side effect, and if it's there troublesome, you can have a Imodium or anything. But otherwise, with this patient, at least we don't have to stop it or reduce the dose. So
okay, right. So even the dose reduction resulted in lower incidence of severity of grade 3. Even after the dose reduction, the incidence is much higher comparatively to the osimertinib in Flora. Okay, right. Next slide, please. Next slide, please. Quality of life comparison. Okay, when the side effects are less, so quality of life should also be good. Next slide, please. Next slide. So comparison the effect of quality of life, EGTK, similarity and difference in osimertinib showed a consistent trend toward a better improvement across score compared with gefitinib. How none of the scores reached clinical significance, so no conclusion can be drawn. Okay, right. Next slide, please. So comparatively to Archer versus Flora trial, so we lung associated with the symptoms. Again, these are overall change from the baseline of the key lung associated symptoms.
So I would request you to conclude your panel discussion in 2 minutes.
Okay, yes. Next slide, please. Next slide, please. Next slide. So yes, sequencing. Okay. Go to previous slide, please. Okay, sequencing. How do we sequence? Right. Is there any need for sequencing? Next slide, please. Is there? Take care. Osimertinib versus comparatively arm first generation TKI to over osimertinib 47% crossover. So first line osimertinib had better result compared to sequencing strategy. Do you agree or not?
Yes, sir.
Yes.
Yes.
Okay. Next slide, please. Because of the very significant PFS and overall survival, right? Next slide, please. So in most of the study, 1/3 do not survive to receive the second line treatment, right? In your clinic practice, how many patients survive to go on the receive the second line? I mean, it's very less, I think osimertinib is available for last 2 to 3 years. I think for the last 3 years. So majority of us are using that. Next slide, please. So 1/3 of EGFR patient treated with the first or second generation TFI are able to receive the second. Only 33% patient are able to receive the second line osimertinib, only second line osimertinib. So 7 out of 10 patients who start on first or second generation TKI will not be able to receive. Yeah, 66% won't be able to receive the osimertinib, right? So next slide, please. Yes. Next slide, please. Now I want to, yes, now this is the, now our patient EGFR mutant advanced non-small cell lung with brain metastasis. Next slide, please. Next slide, go fast, please. So what do you prefer treatment approach? Go to previous, please. Go to previous slide. Treatment approach in the patient if the brain MRI shows isolated CNS metastatic, asymptomatic, multiple small asymptomatic, symptomatic CNS mets, large CNS metastatic near a sensitive size. So what is your approach? You want to go for SRS or EGFR TKI, WBRT, any role of steroid? Please, my panelist, Dr. Ankur, Dr. Mukesh, Dr. Kanika, please one answer to each.
Oh,
SRS,
yes.
your choice, Ankur.
So for asymptomatic patients, nothing. Just give me for in the brain stem. Then I will prefer to give RT. Otherwise, just TKI.
Okay, if the patient is CNS symptomatic, you would like to manage the ICT on the medical management, or you would like to give this?
Just start TKI. If patient is asymptomatic, then just TKIs.
No, if the patient is symptomatic, so the
Then
patient is
then I'll go for RT. Depending on how number of mets are there, whether to go for SBRT or whole brain RT, that will depend on number of metastasis site. But then yes, definitely RT.
okay. Then TKI you will resume afterwards, after completion of the RT, or you?
I prefer to start along with RT only. I don't usually wait.
Okay, Dr. Kanika, if option number 3.
Sir, I will go
TKI
ahead with
plus RT.
radiation and then I will start. So I don't usually give along with radiation.
Okay, okay. Mukesh, Dr. Mukesh.
And if sir symptomatic mets are there, then obviously radiation and then TKI. If asymptomatic, then just TKI. No need of radiation.
Okay, okay. So Ankur, is there any benefit of combining both this TKI? Because
We don't have that much evidence, sir, but some retrospective studies have shown that if you start TKI along with RT, there are more chances of response rates are higher if you start with radiotherapy.
okay, okay, okay. Right, right. Okay. Next slide, please. Next slide, Kanika. So 20% of the metastatic nodes. Wait, yaar. Thoda sa ruk jao, yaar. Please, please, please. Okay. Initial treatment we have discussed, like if the patient limited metastatic confirmed, SRS or surgical resection if the midline shift is there, something like that, or WBRT. Next slide, please. So, 60 to 70% patient eventually develop the brain mass. 20% metastatic non-small cell lung cancer have brain mass at the initial of the diagnosis. Next slide, please. Next slide. So, NCCN guideline for therapy of newly diagnosed brain metastasis with non-small cell lung cancer as primary tumor. NCLC is primary tumor. So, osimertinib is the drug of choice for for newly diagnosed brain metastasis, which are not symptomatic, because it is having the highest penetrance in the blood-brain barrier. Next slide, please. So, I mean, FLORA study against CNS PFS is also clinically very much significant and statistically also significant. Osimertinib has a 12.4 months, 12.4 months and versus standard of care it was 7 months. But I have, I have not gone through the details of this study, because whether they were symptomatic or not, or they have simply started to the, even symptomatic patient were also involved. Anybody has idea about that?
They've taken, sir, asymptomatic patients or pre-treated patient. I think I don't remember about pre-treated, but asymptomatic they have taken.
Okay,
If I
asymptomatic.
remember, I don't actually remember exactly, sir.
Okay, right. But do you do the CSF analysis also?
No, sir. Unless
No.
until patient has symptoms of leptomeningeal disease, no.
Leptomeningeal disease. Okay, okay, right. And next slide, please. Okay, I think so. Lead to 52% reduction in the risk of progression of the disease, even in CNS, comparative to the first generation EGFR TKI. Right. So next slide, please. In the phase 3 RCT of decmotinib, patient with brain mets were not eligible for the enrollment. Next slide, please. So when to start the first line systemic therapy in the advanced adenocarcinoma lung with CNS metastasis? Next slide. Next slide. Simultaneously, yeah, after local treatment of CNS mets, or one patient is stable. So again, uh, next slide, please. I think everybody has answered that. There is a conclusion. Osimertinib result in the significant, improvement in PFS. So, Ankur, my question is that there is no additional toxicity of combining both the two modalities, osimertinib versus along with RT. I don't think so. Ankur?
No, sir, I don't think there. I have not seen any additional toxicity of giving it TKI. At least Jeftinib and osimertinib I have used. I have not seen any toxicity of combining with the RT.
Okay, okay, okay. To conclude that, osimertinib result in a significant PFS over standard of care, 18.9 or 18.9 versus 12.2, demonstrated a significantly, statistically significant, clinically meaningful improvement in CNS PFS also. Fewer CNS events and fewer CNS lesion. First, osimertinib is the first EGFR TKI monotherapy to show the statistically significant OS benefit versus other TKI, 38.6 versus 31.8 months. After 3 years, 28% of the osimertinib arm, 9% is in the comparatively EGFR TKI in the first line of treatment. So after 3 years of treatment, 28% of the patient was the osimertinib arm was alive. Osimertinib presented as a favorable, consistent toxicity profile despite prolonged exposure. Next slide, please. I think we are done. Okay. Next slide. Yeah, Lara, standard of care. Yeah, we have discussed that. Next slide, please. It is a osimertinib is a standard of care. So thank you all for your active participation, and thank you and for your valuable time and taking and giving us your clinical inputs. Thank you all, and thank you Ayush for conducting this wonderful webinar and without any interruption. So thank you, Dr. Kanika, for
Thank
your
you.
sparing your time. Yeah, thank you so much. Thank you, Ankur. Thank you, Dr. Mukesh. Thank you,
Thank
Dr.
you.
Charu. Thank you, Ayush, for the yeah. Thank you,
Thank you, sir.
AstraZeneca, for providing the slides and to discuss the topic. Thank you
Thank
so
you, sir.
much.
Thank you,
Okay, we are
everyone.
done.
Yeah.
Thank you, everyone,
Yeah.
for joining us today. And good night, everyone. Thank you. Thank you so
Good night.
much. Support team, can we go offline?